So thank you so much for joining us today. We have a great presentation for you from two of our resident experts. Let me introduce our speakers. As FWA Client Services Manager, Ed McCormick provides oversight for Cotiviti clients for both postpay and prepay FWA solutions. Previously, Ed worked as both supervisor and investigator with health insurance companies where he was responsible for investigating allegations of healthcare fraud. Angela Mitchell is also an FWA Client Services Manager. Say hello. And is responsible for the oversight of customer contracts for Cotiviti's prepay claim pattern review solution. Before this role, Angela spent more than 6 years working with Cotiviti's postpay FWA solutions as a supervisor managing contracts and serving as a subject matter expert in FWA investigations.
Hi, good afternoon, everyone. Thank you for joining our webinar. Before we dive into our agenda, I need to read our disclaimer to you. The contents of this presentation, both written and oral, are not to be construed in any way as legal advice. This presentation is for informational purposes only. The views and opinions expressed in this presentation are those of the presenters and do not necessarily reflect the official position of Cotiviti Incorporated. So we'll dive in. Before we get into our content, we do have a poll question for you. How does your organization approach waste and abuse reviews? Now, I do realize that some of these, your department may have multiple options here, so please choose the best one. And Angela, what do you think will be the biggest one on the list here?
I would hope that they're utilizing a combination of both, and if not, this presentation is going to serve them well. But from what we've seen, I think it may shift more towards provider-focused reviews.
I would agree with you. Okay. Do we have poll results available?
It's a mixed bag.
Thank you.
It's a mixed bag, but the combination wins with 44%.
Okay. Thank you very much for helping me out with that.
No problem.
All right. So moving on to our agenda, we are going to really discuss primarily two topics today. As our webinar, the title of our webinar explained, we're going to talk about how a claim pattern review can help bridge between the provider-focused post-pay reviews that you're all familiar with some prepay claim-based editing. We're also going to talk about how to sequence investigations using those tools. Then I'm going to hand the presentation off to Angela, who's going to talk through some case studies. It's really going to help to really connect the dots for you for this content. We'll follow up with some key takeaways, and then we'll have some Q&A, as Warren mentioned earlier. So moving on, our objectives here. As I mentioned, we're going to talk about how a combination of these reviews will increase your program effectiveness. What the ultimate goal here is to talk about how sequencing your investigations and your investigative steps will help to optimize your waste and abuse interventions to help improve your results and your recoveries of your program. All right, so moving into how to sequence investigations, I'm going to review this slide with everyone so kind of have an idea of what the different stages are, so we have a better understanding of how that sequencing works. Okay, so the upper left-hand side of our slide, I'm going to start with this piece first. This is our traditional post-pay review. We're all familiar with these in the industry. This is a retroactive review of claims that have already been adjudicated. So I'm not going to spend a lot of time on this because we're all familiar with it. Working our way around the cycle, the upper right-hand side in a clockwise motion. Upper right-hand side, we're going to talk about prepay editing a little bit. What we mean by prepay editing, this is a claim validation step, right? This is an edit that's in place that would catch codes that should not be billed together. That could be due to NCCI edits, mutually exclusive codes. It could be CPT guidance. It could even be some sort of policy that the payer has on their side, some sort of corporate policy. So this is an automated intervention. For example, provider sends in a claim that has two codes. Because the edit catches one of the codes that should not be billed, it's automatically denied. Okay, so that's what we mean by the prepay editing piece. Working our way around to the prepay claim review. So this is a claim-focused review. This is driven primarily by some logic, could be algorithms, AI, that is typically a little more complicated than the logic that's used for the claim validation piece that I just mentioned. Typically, to give an example, we're looking at, a provider submits a claim, has a particular code on it that you want to scrutinize. The logic would look back 365 days to see if this provider had billed this procedure code for this particular patient. Then does another code exist in the patient's history as well? Depending on the logic, yes or no, append would be applied to that claim, and which would request a medical record so that a nurse could perform a chart review on that claim. So that's what we're really talking about with the prepay claim review piece. And then finally, working our way to the lower left-hand side is our prepay waste and abuse. And this is the claim pattern review piece that we're focusing on today. So this is a provider level review. This is placing an edit on a provider, looking for specific codes that the provider is billing, and then being able to request records on a prepay basis, before the claim is adjudicated, to perform that claim level review there, or the chart review, I apologize, for those claims that are tagged. So how these different stages kind of work together, for each stage, you're going to basically learn about provider behavior based on the interventions as they function. So starting with your prepay editing, if you have a provider that's submitting a handful of codes and your edits are denying services, eventually your provider is going to change their billing behavior. They're not going to keep, banging their head against the wall trying to get things paid. They're eventually going to change their behavior. Now, on one hand, they could change their behavior in a positive manner and adjust their billing to come more into a compliance in terms of billing policy. But what we typically see is the provider will change their billing behavior to get paid. They'll begin billing other codes. You could see them adding or removing modifiers. They could begin split billing, to try to evade the edit. So it's that type of evasive behavior that you're going to take, and that's what you're going to learn from your provider. You're going to take that behavior and apply it to your prepay claim review piece, right? You're going to build logic, have rules in place that are going to try to counteract that type of behavior and catch those claims as they come through. Now, your prepay claim review piece, over the course of time, you're going to begin to accumulate data, and eventually you're going to see the same providers kind of bubble to the surface. You're going to see the same providers engaged in the same activity, and that's going to lead you to your prepay claim review piece, your claim pattern review. So you could take what you have learned in your prepay claim review, identify those providers, and initiate a prepay edit specifically on those providers and the procedure codes that are of concern. Now, finally, the bridge that I mentioned before, where your claim pattern review really fits into this equation, is you're going to be able to take your findings from claim pattern review, which are going to be focused reviews. You're going to be able to hand that off to your post-pay, right? So basically, in essence, you're going to be giving your post-pay team knowledge for their review. Like you're basically telling them, we already know this is what the provider's doing, and you can pursue it that way, right? So typically it's been my experience, if you're catching a provider engaged in an activity currently, chances are they've probably been doing it for some period of time. right? So the information that you obtain from your claim pattern review is going to be very beneficial to your post-pay interventions. Okay, so that's how we bridge the gap between these interventions. So this brings us to the next question of sequencing. Where do you start in this pattern? So we're going to walk through that a little bit here. When whether you engage in a post-pay or a prepay intervention at the initiation of your activity is really dependent on where your provider or information originated. If you're going to work with a prepay intervention, typically your provider information comes to you as some sort of data analysis. It could be you see a utilization spike. The provider's billing one code in a very high rate compared to their peers. Could be a code that's has a high reimbursement rate that you want to focus on. Could be that there are new provider is part of your network and they start dumping a large volume of claims. Very different, many different types of prepay indicators, if you will, in provider behavior that would predicate using a prepayment intervention. One last piece I want to point out there is your high confidence of waste and abuse being present on current claims submission. So if your data analysis shows that the provider is currently engaged in this activity, you want to put something in place to catch it as it's occurring, right? So it's a proactive approach to that piece. How do you actually sequence prepay interventions first? So the middle of the page here kind of walks through the steps. First is identify your suspect provider behaviors, which is what we just talked about. The second, you really want to make sure that you validate your concerns with additional data analysis. You want to double and triple check that data to make sure, in essence, that what you're seeing is what you're actually seeing. And then finally, you want to drill down in that data to isolate your procedure codes that are of concern. Now, the reason why these two pieces are very important is you want to make sure, one of the concerns, one of the pain points with a prepay intervention, if you will, that I'm familiar with from talking to different payers is a lot of people are concerned if you place a provider on prepay, you run the risk of overwhelming your review team. You want to make sure that the volume of claims coming in is manageable. You're also dealing with, your prepay reviews are really impacted on prompt payment laws, right? So in addition to wanting to make sure your volume is manageable, you also constantly have a time frame that you're dealing with, right? So it can be stressful, and how you combat that is to really drill down on your concerns to make sure that you're focusing on the issues at hand. You also, especially in prepay, you want to make sure that you're monitoring for those changes in behavior that I mentioned, because that information is going to feed into your other interventions, as we talked about. And then finally, that last bullet piece, take what you've learned and apply it to postpay, because if they're doing something now, they've probably been doing it for a while. Your benefits to this approach, I mentioned this is a proactive approach. So you're not engaging in paying chase. You're tackling the problem before the money goes out the door. So you're minimizing your unrecoverable financial losses. So as a lot of you, I'm sure, are familiar with, your post-pay interventions, post-pay engagement is very resource dependent, can take a long time. So if you're in addition to that amount of time, sorry about that, in addition to the amount of time it takes, you oftentimes run into situations where you might not recover all of your money. There could be a settlement discussion that occurs outside of your SIU department. The provider could go to your network and negotiate some sort of compromise. So you're typically, a lot of times in your post-pay environment, you're not getting a dollar for dollar return on your work. So your prepay interventions really help you kind of get around that piece. You're stopping the money before it goes out the door. And therefore, the last bullet there, you're maximizing savings therefore. So that is kind of an overview of when you would want to engage with a prepayment intervention. Moving on to postpay. What types of things would you see that you would want to initiate? Your first step would be your post-pay intervention. So because post-pay is a retrospective, it's a reactive investigative tool, typically your provider is going to come to you based on some sort of retrospective, or a concern. You could have a member call in with a complaint. They can tell you, I have 6 months of EOBs. The EOB says the doctor said XYZ. I was there. They did ABC. They didn't do XYZ. Right. So you would have to do your due diligence and make sure that you address that concern. And that's something you would want to use your post-pay intervention for. Whether you expand that, whatever your internal policy could be, you could maybe just do a probe sample on that particular patient's claims. Based on your findings, you might want to expand your investigation at that point. Or conversely, some plans might want to expand and still do a kind of like a probe sample, include that patient's claims. But for the most part, that's the type of initiation. That's the type of predication you would have for post-pay intervention. I also mentioned the high confidence in prepay. If you have a high confidence that what your provider is doing is still occurring, you would want to use prepay. Conversely, in post-pay, because you're looking at prior behavior, there is really no guarantee that the provider's doing what they're doing now is exactly what you've already seen in the past, right? So you have kind of a lower confidence that their activity is currently still going on, right? So that's something else you would want to engage with your post-pay type of review. Moving on to sequencing, very similar to post-pay. You want to identify your suspect provider behavior, which is what we just talked about again. Again, you want to validate your data. You want to drill down on in your data analysis to identify what your services of concern are, and then initiate your audit. And again, that's going to help you build those guide rails in your post-pay. As I mentioned, these investigations, they take time, lots of resources. And if you put these guide rails in place at the initiation of your investigation, it's really going to help you maintain your efficiency and your effectiveness in your program. Benefits to this approach. I mean, you're obviously going to validate your initial waste and abuse concern one way or the other. Either that member was 100% correct and all 6 months of procedures were billed incorrectly, or, that could be a customer service type aspect where you educate the member and move on. This also has a very large impact on eliminating your potentially fraudulent provider claim submissions. And your post-pay interventions are going to be your main tool for maintaining your fraud compliance, right? So that's the last piece for post-pay. Now, when would you want to maximize both of them? I'm sorry, you would want to maximize your results by using both of them. There are some situations when parallel interventions are appropriate. For example, if you have a concern and you have a high confidence that maybe your concern wouldn't be caught by one of your prepay interventions, like maybe your claim validation could be evaded, or that claim-focused review could be your provider could bill in a way to circumvent that. You would want to put both in place, both post-pay intervention and a prepay intervention, to not only catch what is occurring now, but also to be able to double back and check on that provider behavior in the past. Also, if you have significant current claim volume and historical claim volume, if it's a large provider, they've been part of your network for a long time, you have a lot of data to sort through. So it would be appropriate to engage in both interventions at that point. Moving on to how you would conduct these parallel interventions. Again, very similar. You want to identify your target behaviors and your providers in general. Definitely want to validate your initial concerns, drill down on your codes, and then initiate your audits simultaneously. Now, some of the benefits of simultaneously engaging in these interventions, it combines your reactive and proactive approaches. Really, The big bullet, in my opinion, is the third one on the list here. You have a very substantial probability that the provider is going to change their behavior if not only are you, did you send them an overpayment letter with provider education, but you're also stopping more money from going out the door. You're definitely going to change provider behavior by taking this simultaneous approach, which in turn, the last bullet, mitigates your future risk.
Let's jump to the next slide. And as Ed mentioned, the way in which we approach both provider reviews and claims reviews is to make that distinction between fraud and waste and abuse, right? So many times we have a credible allegation of fraud, but only after we've done that initial audit where we've identified instances of waste and abuse. So as Ed previously mentioned, we always recommend, obviously when possible, using a combination of both pre and post pay together. And so our first case study that we're going to walk through in the next few slides really highlights the benefits of using both the pre and post pay approach, as a lot of times it can help elicit responses from unresponsive providers. It can also, work to reduce abrasion in terms of provider abrasion, which we see a lot on the post pay side. And so let's walk through our first case study. Ed, if you could jump to the next slide. Thank you. So our first case study is going to focus on genetic testing. This is a problematic area. I think we can all agree. HHS OIG has included this within their yearly work plans as they've identified an increase in genetic testing over the last several years. This is due to the cost of genetic testing being as high as it is, right? So the services themselves are not only frequently abused by providers, but laboratories as well. We have a great statistic here that in fact, between 15 and 40% of genetic testing requests are actually coded incorrectly. And we here at Cotiviti see that quite frequently when we receive medical records. There's also the potential for excessive billing of genetic testing. And this is potentially indicative of medically unnecessary services. We have a great slide coming up next where we identified this with the out-of-network lab that we're going to take a look at. So the case study today is a Cotiviti provider that we identified both on the pre and post pay side across several of our clients over the last several years. So this provider, we were able to get a holistic view over several years of data for different clients, both on the pre and post pay side to present to you guys today. Ed, next slide. Thank you. So out of network lab, many of you who have seen Aaron's presentations or our other presentations in the past are probably thinking out of network. That typically means unresponsive and unrecoverable, right? Well, I'm hoping after we walk through these slides, your opinion will change once you see that using both approach of the pre and post pay interventions can help combat that, right? So regardless of the approach that we take, whether that be pre or post pay, we're always looking at the provider's billing history to kind of determine what patterns are occurring. And from there, that's when we make the decision, do we take the prepay intervention or do we go the post-pay route? For this particular out-of-network lab, the behavior was so egregious that it only made sense for us to approach it from both respects. So this out-of-network lab was identified as a significant outlier for many different things. We're going to walk through a few of them at a high level. So we conducted outlier analysis to start. I'm sure many of you at your health plans do that as well. I like to refer to it as peer comparison analysis. So I wanted to see how the provider compared to their peers for certain codes that they were billing. And I want to point our attention here to CPT code 81479. It's an unlisted code. And the reason why I want to focus on this code is the fact that there are over 400 current CPT codes that cover over 150,000 genetic tests. However, the high utilization of the unlisted code by the provider seems suspect, right? So that was the first red flag for us. We found other items such as unbundling, duplicate billing, high average number of patients with the same genetic test. Again, we have a great example on the next slide, and then billing of genetic tests without a corresponding diagnosis. Ed, next slide. Great, thank you. So this example here is just one of many that we saw across the majority of the providers' billing. So the billing pattern was consistent across the population we like to refer to this as blanket billing, right? So the majority of the patients, regardless of their diagnosis, were receiving the same battery of tests, multiple tier 2 molecular pathology. So we can take a look and see here on the screen that this individual received this battery of tests, not only on one date of service, but on multiple dates of service. And for this particular patient example, it raised a few red flags given their diagnosis, which is chronic kidney disease, stage 3 unspecified. So one thing that we were considering while we were doing our initial analysis was, given the stage of the patient's care, was it really appropriate and necessary for them to be billing that battery of tests for that patient? And then one other thing that we were able to do here at Cotiviti, because we have clients that span across the country, we have the availability to look at payers across the country, right? So Ed, if we want to hop to the next slide with our pretty map here. Awesome. So with this particular, we were able to look to see data across all payers. So you can see this out-of-network lab was paid a total of $142 million across all states. So this was a great tool for us to use not only for the post-pay side, but for our other clients to say, hey, we're seeing these heavy areas of spend, particularly on the East Coast. So New York, for example, New Jersey had about 7.6 million in exposure. And Massachusetts, I know, had 5 million, and then Texas, obviously, where I am. So it was a great way for us to say, hey, we know you guys are doing stuff on the post-pay side, but we are finding heavy spend areas over here in this part of the country and over here. And so it was a great way for us to use a prepay intervention as a first step for a provider review. And the next slide. And then lastly, just taking a look at prepay edits here, we wanted to provide you guys with some additional information as to other areas of focus that we were looking at for this particular provider. So there was significant usage of modifier 59. I think we can all agree that that's pretty typical and not too surprising there. However, we also did notice that there was a steady increase in the number of claim edits. So we typically, for many of the providers, we see that when they believe that they are being watched or somebody is looking at their billing, they start to slowly increase their billing to hopefully increase their overall revenue. And when this happened, that's when the prepay edit flags started firing. So again, this was just another great data point for us to say, hey, this provider probably warrants additional investigation. So to bring it all together, we took a step back. We looked holistically at this provider, right? So we took our first step with the outlier analysis, what we saw there, the upstream activities that we're looking at here, paired those together, and that gave us the confidence to validate, to say, this provider is worth moving forward with. We know the spend's there, so post-pay, you can open an investigation there. But again, because this provider was continuing to bill and we're seeing that steady uptick in the prepay edits, it was, again, validation that prepay intervention would assist our clients with potential savings up front. So we wouldn't be doing the pay and chase that Ed talked about earlier in the presentation. Now, I did mention that we did receive several medical records. While the lab itself was unresponsive, for many of our clients, we did receive medical records. So we were able to conduct several medical reviews. Ed, if you want to jump to the next slide. Thank you. So the provider review resulted in 100% denial rate. I included here just a few of the denial reasons: failure to provide records, missing invalid complete documentation, which is pretty typical. There was not ordering physician information on the lab requisition forms, And then also there wasn't documentation within the record to indicate how the genetic testing that was being billed by the lab was going to be used or related to the patient's current history of their condition or past medical history. This provider was identified during the first quarter of 2023 as a prepay candidate in our CPR program. And so the initial identification of this provider took place through an algorithm within CPR that flags for the excessive individual therapy per day. So we'll walk through the findings, similar to the first case study, what the initial analysis looked like, putting the provider on prepay, requesting records, getting those records, and then what those records showed once we got them in. Next slide, please. Great. So as I mentioned, this particular licensed clinical social worker was billing a psychotherapy code. And after we saw the algorithm flag for excessive number of individual therapy, we wanted to dig deeper to see what that specific code was. And I don't think it's a surprise to anybody, but it's CPT code 90837, the 60-minute psychotherapy. And so what we're looking at here, similar to how we conducted our previous case study analysis, we wanted to look at outlier analysis. So we ran a peer comparison report, did some additional analysis to see how the provider compared to their peers in terms of both total billed and percent paid. As you can see on the screen, the provider was a significant outlier. We also identified them as an outlier for delivering telehealth services, which we will see later in the medical records. We were actually able to substantiate that information. They were also an outlier in terms of the number of patients that they were seeing compared to their peers, as well as an outlier for exclusively billing the individual psychotherapy code. So that just means they were billing the highest level. So rather than billing a 30-minute psychotherapy, a 45-minute psychotherapy, a 60-minute, a mix of those, they were exclusively billing the 60-minute psychotherapy. So again, these were initial indicators that were throwing up some red flags for us. And of course, we wanted to do some additional digging to ensure that there weren't any other substantial problems with the provider's billing. And next slide. And I think typically what we see and what we have been seeing over the last several years when it comes to the 60-minute psychotherapy code, an impossible day scenario tends to go hand in hand, whether they're billing the place of service 11 in their office or delivering the service via telehealth. We are seeing the impossible day scenario sneak up with the excessive billing of the psychotherapy codes. And that's actually what we saw here. So this provider was an outlier with the number of services billed per day. We took the conservative side of things, which we do when we're looking at an impossible day scenario. As we know, certain situations arise. A provider may work over 8 hours. They may work what exceeds what's listed on their office hours. And so what we're looking at on the top right side of your screen is just a high-level overview of some of the codes that were billed and the time allotted, the minimum time for those codes. And then below, we wanted to provide you all with a service date example of what the impossible day scenario looked like. So this provider, for one health plan only, billed, again, on the conservative side, about 18.25 hours, again, one date of service, with potentially up to 23.67 hours. It is unlikely that this provider is only seeing these members from this particular plan. They're probably seeing members from other plans. And we did verify through open source research that the provider does accept multiple health plans insurance. So again, this to us was indicative of a potential impossible day scenario and something that we wanted to take a look at for our prepay. And then, as I mentioned, this provider is on prepay review. So what we did was we decided to, based off of our initial analysis, we placed the provider on prepay review. We pended the claims, requested medical records. For this provider, we did receive medical records. So I will preface this by saying the review is ongoing. We are continuing to receive records for this provider. So we just wanted to provide you all with a high level of the medical review findings that we have been seeing thus far. And next slide. Thank you. So time was not documented, right? So I think this is something that we frequently see. The actual time that the provider spent face-to-face with the patient was not appropriate for the psychotherapy code that was billed. We also saw that there was no initial evaluation or treatment that was documented within the record. There was also no name or credentials within the record. So we were not able, in viewing the records, to determine who actually provided the service. Was it the provider? Is somebody billing? Is there another mental health professional that works there that is billing under the provider's MPI. There was no documentation within the medical record that would give us that information. And then some of the other findings, and if you want to jump to the next slide. I spoke earlier about the telehealth outlier findings that we found. And so we were able, as I mentioned earlier, to substantiate that once we received the medical records, right? So the telehealth requirements for psychotherapy were not documented. So according to CPT guidelines, you have to have some type of documentation regarding what you use to perform the telemedicine visit, right? So whether that be audio, two-way, video, none of that was documented within the medical record. So we couldn't substantiate that it was actually performed via telehealth. And then to piggyback off of that, we also saw issues as it relates to place of service 11 being billed incorrectly. So place of service indicated in the record were 3 of the following, and I'll go through these at a high level, but they indicated in the record that services were being rendered at a barn. So they were riding, petting horses. Most health plans do not cover that service. This particular health plan outright does not cover it. So that in itself was suspicious. And so in diving more into the record in terms of, okay, you're at the barn, you're riding, you're petting the horses, what else are you doing? The provider had indicated equine therapy was taking place. So this is a therapeutic procedure where where an individual is grooming the horse, feeding the horse. Maybe they're leading the horse around with the supervision of a mental health professional beside them. And then hippotherapy. This was new to me, maybe new to some of you all as well. This too is a therapeutic and rehabilitation activity. And so this is really used to help build strength, coordination, and balance. It's typically seen to benefit individuals who may have a condition such as cerebral palsy. So as I mentioned, we saw the barn as a place of service. We also saw the school. If we're coding that correctly and indicating it correctly in the record, it should be place of service 03. Again, the provider was performing the service according to the records in a school, but they were billing place of service 11. We also saw that several services were rendered in a park when she indicated that they were rendered in an office, right? So as I mentioned, we are actively doing a review. This provider is still sending in records. And so 2 things can happen, right, at this point. And this kind of ties everything back from what we heard from Ed at the beginning, and using that combination of both a pre and post pay intervention together. We have seen suspicious billing behavior. We've substantiated through medical records review. So our recommendation would be to continue reviewing records, keep the provider on prepay review, but then also recommend potentially opening up, if it's not already open, a post pay. And then they're running side by side, and you're making sure that you're getting the money before it goes out the door. And if money has already gone out the door, you're minimizing as much as possible that pay and chase to get your recoveries back.
So our key takeaways today, we talked about how CPR not only helps you, our claim pattern review program not only helps you identify real-time schemes, also are able to be that bridge between your pause and review workflow to basically help improve and increase the efficiency of your programs. It also it contributes to that feedback loop. As I mentioned, some of your interventions can be resource dependent. Can take a lot of work and a lot of time. So being able to use these pieces together and bridge your interventions together, help them communicate, help your flow of your investigative work is really going to help you improve your compliance as well as your efficiency of your interventions that you're using. And then finally, Cotiviti has the ability with our claim pattern review clients, as Angela illustrated, to use cross-payer analysis to help identify new schemes and new providers as they appear.